First, we're going to start with preoperative optimization and obesity, the impact of obesity on hip replacement and knee replacement. We talked a bit about it in knees. So Amar, you're at the front of the line. Does it affect patients with hips more than knees, or is it the same? What are the implications?
I think very often we'll see people that have large bellies and rather thin legs, making knees a little bit more easy to do. But in a hip, when you have a pelvic distribution of your adipose, that can make the exposure of the hip, much more challenging. And so in general, what I try to teach my residents and fellows is a knee is probably in general more difficult than a hip, but a difficult exposure of a hip is far more challenging than a difficult exposure of a knee.
Does anyone do an anterior approach on the panel? Yeah, so do you do an anterior approach on all of your patients, or do you select them?
Majority.
Yeah, so if there's an obesity cutoff for anterior approach?
I find it, there's no obesity cutoff for me, even though I realize that the wound complications are slightly higher generally in obese. And what I do is take an incision slightly laterally and superiorly when I reach up and don't cross the crease. Yeah. But I personally feel that in most cases, it's easier to do a direct anterior than to do a posterior in a patient with a lot of adipose tissue on the buttock.
Yeah, so you avoid that groin crease. If they have a fatty pannus, it may increase your risk of infection. You move your incision. But I agree, they say you're never too fat to sit. So when you extend the leg, there's often space there. Okay, for the posterior approach surgeons, is there anything different in the setup or the exposure or approach for obese patients? Does it affect your accuracy? It won't affect yours, Dr. Mayman, because you're using image-based registration for your navigation system for your robot. But what if you're not using a robot, if you're using conventional instruments? Does the obesity affect your accuracy? Yep.
I can, as long as your exposure is adequate. If you expose your acetabulum adequately and use the landmarks correctly, it should not be a problem. Although I use the technology as well, like robotics.
Yeah, so if you're using local anatomic landmarks, it shouldn't affect your accuracy.
I will say I have different retractors for obese patients, so they're longer and they're deeper, and if you don't have those, it can make life more challenging.
Okay, so anything different? Is there a cutoff? Does anyone have put up your hand if you've got a cutoff for BMI for hip replacement? Nobody has a, yes?
Usually 40.
40?
For Asian patients, that's quite a lot.
Okay. So would any of you try to optimize their body weight before the surgery? Do you ask them to diet? Do you send them for bariatric surgery? Do you put them on the GLP-1 agonists?
It doesn't work a lot of the time because of the hip pain, they don't walk. If they don't exercise, whatever dietary thing, they are not very keen. The problem in India is we have got females with a short, thin bones and very large fat. So they have got a central distribution of fat in Indian patients. So huge thigh fat and huge fat on the hips. The problem come many times is when you're doing THR, the offset is very small, and then the risk of because of middle thigh fat, the hip may dislocate.
So there's a higher risk of dislocation with obesity. Is there a higher risk of anything else?
Because the thighs are very big, and then when they tend to walk, the risk of I try to increase offset by a little,
I agree,
hopefully, and use the largest possible head I can. Although sizes in the female are rarely beyond 44, 46, so I don't have too much option there.
Yeah, that's seen in the Australian registry too. Obesity is associated with a higher risk of dislocation, as well as a higher risk of wound problems. So you may want to use larger diameter bearings. If you believe in dual mobility, you may want to use that. Increase your offset or other measures to try to reduce the risk of dislocation.
About the bariatric surgery,
yes,
that's an absolute no, because the bariatric surgery increases your risk of dislocation. It leads to loss of muscle mass. So every evidence shows that if you have bariatric surgery, your risk of dislocation is multiplied.
Okay, and there's also theories about them being malnourished as well. So there's, I think we spoke about it yesterday in the knees, and Amar said that the literature was confused about the role for bariatric surgery. So if you've got a patient that's on Ozempic or Mounjaro or one of these GLP-1 agonists when they come to surgery, we know that that slows gastric emptying. So is there anything different about the anesthetic of a patient that's on Ozempic or Mounjaro?
So we actually have a pretty strict policy at HSS now. So If you're on one of these medications for diabetes, for sugar control, then you stay on it, you don't stop. If you're on one of these medications for weight loss, then you need to stop 1 week prior to surgery. And we actually make the patient's NPO full 24 hours before surgery. And then if there's any concern, the anesthesiologist will actually do an ultrasound of their stomach in the preoperative holding area. And if they still have food in their stomach, then it's a decision between the surgeon and the anesthesiologist how urgent the surgery is.
Right, so that's important. These drugs delay gastric emptying, so it's a full 24 hours of fasting before the surgery. It's a week, stop the drugs, then you treat it. What about rapid sequence intubation? Do you ever do a rapid with the cricoid pressure and the rapid sequence intubation to reduce the risk of aspiration?
Yeah, so look, what we do on the stage here is mostly elective surgery, so most of the time these cases will get canceled if they've still got food in their stomach, but if it's a hip fracture, if it's something more urgent, then I think that's prudent.
Okay, right, we'll move on to the next. Thank you very much. What about anemia? So I might ask Dr. Bende, what do you test? Do you do a hemoglobin prior to surgery?
Oh, always. Usually Indian patients have very low hemoglobin, especially ladies.
Yeah.
Average is about 10 or 11 grams.
Okay.
So,
and if it's below 10 or 11, what would you do?
then I would prefer to wait unless it is an emergency like a fracture. But otherwise we give them on medication. Sometimes I send them to a hematologist to see whether they can give IV iron therapy to improve it. We can easily wait for maybe 2 to 3 months we need to get at least 1.5 grams up.
So investigate the cause of anemia, maybe give them an iron infusion if they're iron deficient and all those things. All right, what about malnutrition? Dr. Kalkani, do you screen for malnutrition?
Yeah, I mean, if patients who have low albumin, obviously they go and see a dietitian because the post-operative wound complications as well as wound discharges and healing is affected in these patients. So I think they do need to see, and as we said, it's an elective operation. So we really need to optimize these patients.
Okay, anyone else do anything different? No? Okay. What about vitamin D deficiency? Vitamin D deficiency can affect a whole range of things. Do people routinely screen for serum hydroxyvitamin D? So Dr. Jungid, perhaps, do you not routinely screen for vitamin D? Oh, so he's not here, sorry. Dr. Malhotra.
So we follow what is now called, and it was mentioned yesterday, bone health optimization. And every case of elective surgery must have bone health optimization, which includes doing the basic tests like looking at vitamin D. Particularly in India, we have a very high incidence of deficiency of vitamin D. We would definitely like to say for an elective surgery, we must start them on treatment before taking them up. So I'll typically wait for about 3 months before doing a surgery if the bone density is bad.
Okay, and maybe check for chronic kidney disease as well. What about osteoporosis? Is that something you look for, Dr. Sharma?
We ensure that in a preoperative setup, because these are the elective surgeries, so we want to prepare the patient with the enough amount of exercises and calcium and vitamin D intake. But mostly the patients, we don't delay the surgery. Post-operative, we ensure that these patients, they take up the denosumab and teriparatide. Both preferably calcium, vitamin D, along with the exercises.
So calcium, vitamin D, and teriparatide, which is a parathyroid hormone, denosumab. So do you do DEXA scans on everybody over a certain age? Or?
If the patient is osteoporotic, which is visible, and in some cases not as a routine.
So if you look at the X-ray and they look osteoporotic, or if there's a history of fragility fractures, perhaps you might do a DEXA study.
The patient has been on the bed for a long time.
Yeah.
Maybe in those cases.
Does anybody routinely do DEXA studies over a certain age?
Above 65 it's recommended, but we still don't follow it, but we do definitely do it for high-risk patients. Smoker, alcoholic, female, early menopause, short menstrual history, maternal history of osteoporosis or maternal history of fracture. We go through the entire gamut of risk factors, and if there's any, we do it. We still are not doing routinely for everybody above 65 in India.
Okay.
Bill, can I ask a question?
Yes.
What is more important clinically? Is the number on a DEXA scan important, or your feeling as a surgeon when you open the bone, try to broach it or try to rim it, is more important in deciding how good or bad that bone is?
Yeah. See,
What do you think?
I've done a lot of resurfacing, and there's some work from Laurie Cohan in Australia showing that DEXA study does not predict femoral neck fracture if you're doing resurfacing. So he did hundreds of patients and couldn't predict the risk of femoral neck fracture with resurfacing. So it's general, the number of comorbidities, the number of pills they take, their health are better ways of assessing it than that.
So I look at all the hip patients get a lumbar spine X-ray. So you look at the lumbar spine, it's more predictive of the osteoporosis.
Okay.
Second, the opposite normal hip, we look at the SINC index, so the loss of trabecular pattern. These two are very useful in predicting the level of osteoporosis. If they are grossly osteoporotic, we get the DEXA scan. Otherwise, intraop, we see the bone quality, and then immediate same admission, we get the scan and treat the osteoporosis simultaneously.
Okay. So David, your wife's an expert on this, and I think she said that you should be doing. Do you do what your wife tells you to do?
I do. So I was going to say, I'll channel my wife here and tell you that DEXA scans tell you bone density. DEXA scans do not tell you bone quality, and they're different. So a DEXA scan is one of the tools that we have, but it's not the only tool.
Yeah.
Unfortunately, we don't have the trabecular bone score in India yet, but we do look for, in a bone density, we look for 3 additional things: the vertebral fracture assessment to see that there's no compression, trabecular bone score if I had, that's my wish list, and a FRAX prediction of the risk of fractures. I think all that will lead me to start osteoporosis treatment before taking elective surgery.
Okay.
Again, there is a correction factor if the patient has inflammatory arthritis or diabetes.
Yes.
So you need to add that correction when you are dealing with these patients.
Okay. And we might get onto some plain X-rays. Well, we'll see some plain X-rays in a minute. But what do you look for on the plain X-ray for bone quality? You look at canal flare index. Do you look at cortical thickness ratios? What do you look for? Oh, you got something else to say?
I said I look at SINC's index, the trabecular pattern, primary
Okay.
and secondary trabeculae.
Okay.
So if this deficient, we grade is 1 to 6. They are deficient, we always subject them for a DEXA scan.
Okay. Comment?
Well, X-ray of the hip is very useful in assessing just the plain X-ray of the hip. The trabeculae pattern is very important. Something described from India, the SINC's index.
Okay, so we'll get some X-rays later on, but let's talk now about diabetes. Do you all measure hemoglobin A1C prior to surgery?
Yeah.
You do. And hemoglobin A1C gives you the history of glycemic control. So do you have a cutoff? 7.5% is one of the 7.5%. If it's over 7.5%, it means the glycemic control's been poor for the last month. So what would you do in that case? Would you delay the surgery? Control it? Yes?
Well, it'll take about 3 months for you to delay because it doesn't go down very fast.
Okay.
And let them take help of some diabetologist.
So what about these selective glucose transport inhibitors that work in the kidney by blocking the reuptake of glucose? A lot of the diabetics are on those. Do you continue those or do you stop them? Amar?
Yeah, I mean, I don't have much experience with these,
Yeah.
but sugar is becoming a much bigger issue for us than obesity and BMI is right now.
Yeah. So those inhibitors are associated with a risk of ketoacidosis if you don't stop them. So the recommendation is to stop them for 3 days before the surgery.
One thing that we follow is that since HbA1c will tell us only after 3 months.
Yeah.
So the better way that we follow is that we blood sugar fasting and postprandial, and we ensure that the fasting sugar is measured every day under the observation of our physician. And the moment you have the reasonably controlled blood sugar, which is less than 120 milligram percent, and it is maintained for a week, we take up the patient mostly.
Okay. Thank you. What about dentition? Do you routinely check the patient's teeth prior to surgery? Anybody? Yes, you do. How do you check their teeth? You look at their teeth, or you?
Yeah, I ask the patient, do they have any dental caries? So if they have something, I refer them. I look at the teeth also.
So that's because of the risk of infection if they
Yes.
have an infected tooth?
Yeah.
Yeah. Okay. I must say that's something that we don't routinely look at, but in the population I see, usually they've got good teeth. So what about the rest of the, what about tobacco and opioid use, opioid abuse, we could say? If your patient's a smoker, would anybody do anything with them?
Chronic smoker, usually the anesthetist picks up, even if they don't tell us. They come back as chronic smoker, you advise them to abstain for 4 weeks. And they usually ask the spouse whether they're adhering to that. If they say they're not adhering, I get the nicotine level assist.
So does that improve their chances if you stop smoking for 4 weeks?
I feel I had a lot of complication with chronic smokers, especially infection, failure of arthrodesis, multiple problems.
Yeah. David, what do you think about tobacco use and smoking?
Yeah, so we tell everybody to stop. We don't test them. There are lots of people now that are testing them. But there's good data out there that if people stop smoking even for 10 days prior to surgery, the oxygenation levels in the tissues go up to improve wound healing. So some of these smokers, we're not going to stop them from smoking, but many of them will stop for 2 weeks prior to surgery.
This is specifically for those who come to an outpatient clinic with mild cough. Smoker's lung with mild chronic bronchitis.
That might improve with a short holiday. Okay, so
but the big issue is that do they actually stop?
Yeah,
because most smokers, they say that they stop, but they actually continue.
Yeah.
That's why the nicotine level comes. Once you have the nicotine level with that, then they cannot cheat you.
So David, you also come from a country that's said to have a fentanyl epidemic. Do you see patients that are fentanyl addicted, and how do you manage them?
So we definitely see people that are chronically on opioids. Most of them these days come because of chronic back pain, so they've been put on opioids by pain management doctors for back pain.
Yeah.
It's actually less today than I think it was even 5 years ago, but we do have them see our pain management specialists prior to surgery and try to at least lower the dose of opioids that they're taking prior to surgery. I don't think we make them stop completely.
It's actually they've gotten very good at just screening the patients themselves that are booked for surgery, and the pain service will identify patients that appear to be chronic opioid users, and will get urine tox screens on them and evaluate them, and let us know that these patients are high risk and that they would be challenging patients to care for post-surgery. So, I think it's like anything else. We talked about, having a multimodal approach to infection, to rheumatoid patients, so all these patients require, lots of people to take care of.
So you say they're high risk. What's the risk? What are the high risk of if they're on fentanyl, if they're on opioid chronically?
Well, there's risk of withdrawal. There's risk of just having difficulty with pain management after surgery, and all those other.
So do you give, if you have somebody who's been on opiates long term and you try to reduce it, and then post-operatively, do you give them opioids for pain, or do you say you can't have any?
Well, that's how our pain management team helps us, assess that. And so that, the sooner you know about a patient's potential problems, the easier it is to manage going forward. Versus, identifying someone post-op day 3 who has gone through all their meds already, and they're demanding more and more, and so that's a much more challenging patient.
But you'd still give them opioids for pain control along with your multimodal pain management.
They will try that, or try alternative medications, and put them on a lot of these. Narcan, or not Narcan, but opioid agonist type medications.
Yeah, I think there are also two separate patient populations. There's the patient population, again, usually chronic back pain, getting narcotic pain medications from a pain management doctor, and then there are people that are just taking opioids from the street. And really what we're trying to weed out are the people that are not under the care of a pain management doctor, but getting opioids somewhere else. And they're just very difficult patients to manage afterwards because they're very demanding. They're calling the office, trying to get pain medication.
So do you see that in India as well?
We don't have too many, at least not obvious.
In India, the big issue is that opioids are not easily available. The only thing that we can give is the opioid derivative, the tramadol. That's the only thing.
So even for perioperative pain management, it's difficult to get access?
Very difficult.
Okay.
We used to see Fortwin addiction when it was readily available, and that was a terrible thing because they'll inject themselves and get scarring and muscle contractures and skin scarring. That possibly one of the most terrible addictions I've seen.
Yeah. So we don't have the same problem as the US with opioid addiction. It happens, but it's rare, and we have good access to the drugs, so we use them for pain management. So what about cardiovascular evaluation? Does anybody do a routine echocardiogram or a stress echocardiogram?
So we do regularly 2D echo and dobutamine stress echo, because in India, the cardiac problem are very high. It's supposed to be capital of cardiac and diabetic problem in the world.
Right.
And we have seen people who are in late 30s, early 40s getting a massive coronary blocks and infarct. And most of you must have heard, I mean, the doctors just falling on the dais in their 45 and suddenly had an arrest and dying on the table.
So even for a young, fit patient, you'd
yes,
get
they look young, they look fit, but you do DST and then you find out there is ischemic changes. Then you have to do angiography and find out if something need to be done. And many times they do have significant coronary blocks.
Okay.
It has increased a lot after the COVID.
So why is there so common cardiac disease in India?
It may be the
Smaller
genetic,
coronary.
because they have found that even American Indian, I mean Indian origin Americans, they have a higher risk of
So some sort of genetic
cardiac problem. It's genetic,
predisposition.
yeah.
I routinely get a cardiologist's opinion. They decide what procedure
Yeah,
to be
that's
done.
what I do too.
Generally, we don't subject them to stress echo, dobutamine stress test, because it increases the stress for the heart.
Yeah.
So either they take a angiogram or give the fitness.
Another problem in Indian patients is they get operated very late when they can hardly walk, so they'll never get an angina because they've not been walking.
Okay.
It has so happened with me that the patient got operated, was so excited, said, I walked 500 meters today on day 2, and day 3 he got angina.
Okay.
And that was the day, this was 20 years back, so we decided every patient who's disabled and cannot walk must be subjected to echo before the
Okay.
visit.
So what about in the US? Are you routinely doing echoes? No. So we don't routinely do them either unless they're over 65 or 70, or if there's a history, we'll send them to a physician and they'll organize it.
Yeah, we do like anybody above 65,
Yeah.
and all the stress echoes, and
Yeah.
less than 65, 2D echoes a must.
Okay. What about all this stuff with spinopelvic analysis, the standing lateral view of the spine, the relaxed seated, the flex seated, the pelvic incidence, PILL mismatch, change in pelvic rotation? Does anybody, you're routinely doing that? Absolutely. You look like you don't believe in it though, David.
So I think there's been a lot of talk about this. John Budorczyk at our place has published a lot on this. I've been involved in some of it. It sounds very complicated to a lot of people.
Yeah.
To make it super simple, if their pelvis changes less than 10 degrees from sitting to standing, those people are at higher risk.
So they've got a
Average is about 20 degrees.
stiff lumbar spine. What about standing spinal deformity? Flat back deformity when you stand.
Yep. Those people are
At higher risk as well. Yeah.
I think what we've been very good at doing is determining which patients are at high risk. What we haven't been good at doing is saying, how should that affect the acetabular position, and what should we do to treat them, whether it be dual mobility or something else. In the past, we were going towards dual mobility, and now we're moving away from that, as I mentioned the other day, and using larger and larger monoblock heads. So yeah, I still don't think we have the answer to the problem, although we're identifying the problem much more clearly.
And does anyone change their cup target if they've got a stiff spine, their functional cup target? Yeah, so you increase the anteversion a little bit in stiff spines?
Depends on the deformity.
Yeah.
So you reduce anteversion if it is flat back.
You reduce anteversion if it's flat back.
Yes.
Okay. Are you talking about the functional position of the anteversion? You reduce it?
Yeah. If
Flat
it's a-
back is like a stuck sitting, so
Yeah.
you need to reduce the anteversion.
Okay.
And if it is excessive lordosis, and you have to make sure that the excessive lordosis is not because of the flexion deformity of the hip, and that also can cause excessive lordosis. So if that is because of spinal case, then you have to increase the anteversion.
Okay. All right, we won't get too much into that. There's all sorts of things we could talk about there. What about choosing the appropriate implant for your patient? So does everybody do templating of their patients to select? You don't do templating, Amar? How do you choose the implant?
So, one of my mentors at one point said I stopped templating after my 1000th hip, and I sort of feel the same way. I mean, I do look at the x-ray,
Yeah.
and I have a sense of what's going on. I don't put the actual templates on anymore. My fellows will do that. And I try to use one implant for 95% of my cases, and if that doesn't work for me, then I'll switch to another implant design that is more appropriate for that bone. But it's very rare that I switch.
Okay. All right, so what about antibiotic prophylaxis? Do people use antibiotic prophylaxis routinely on all patients? Are you using cephalosporin? Yes. Using it for 24 hours? Anything different to cephalosporin for 24 hours?
So many of our patients are going home same day, so they're getting single dose.
Single dose?
A dose preoperatively, and that's it.
Okay, are there any high-risk patients where you'd extend that, Amar?
We are struggling with that concept right now, but I think it's happening more and more. A few things I've learned, if you're going to use vancomycin because of some allergy or some reason, I now will add a aminoglycoside to the vancomycin to get more gram-negative coverage for those patients. But yes, there are certain patients now that we would give extended antibiotics to, and infectious disease seems to be a little bit more understanding of that situation. But we have no real good guidelines as to who when we should do it.
We get a lot of heat from the pharmacy about using vancomycin as well. But I'd argue if you're using a prophylactic antibiotic, it's got to be effective against the organisms that you are trying to target. Otherwise, why use it? What about tranexamic acid? Does everyone use tranexamic acid in surgery? Anyone not use tranexamic acid? So there was a lot of intra-articular tranexamic acid I saw in India. We use it IV. Do you all use it intra-articular?
I do both.
Both?
We do both, yeah.
I give intra-articular, 200 milligram, and repeat it.
How many
after
milligrams?
6 hours.
How many milligrams?
I think it's
1 gram.
Yeah, 2 grams.
2 grams, okay. What about this extended dose for 3 days? A paper from your institution, David.
Yeah, so I was going to ask you. You talked about doing that in your knees. Are you doing that in your hips as well?
Yeah, well, I saw Peter in Calcutta last year, and he presented that work that was done at your institution on knees. And then he came to Australia again in October. So I'm using it for knees and hips, and we're actually looking at doing a study on hips because the work hasn't been done for hips.
That's right. We don't have any data on hips.
We don't have any data on hips. So are you using it for knees for 3 days or for hips?
So I'm not using it at hips.
Yeah.
And I'm using it, maybe I should be using it in everybody. The knees that seem to bleed a little bit more, those are the ones that I continue afterwards.
Yeah. Okay. DVT prophylaxis, what's your drug of choice on the panel? Maybe we'll run down the panel starting with Amar. What's your drug of choice? Aspirin.
Clexane for 3 days when the patient is in hospital, and then aspirin followed by that for 6 weeks.
Aspirin.
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 Clexane followed by newer oral anticoagulant for 14 days for knees, 35 days for hips.
Okay.
Aspirin.
Aspirin.
Aspirin for all the patients, but the high-risk patients like the high BMI patients, rheumatoid patients, relatively sedentary patients, we start the Clexane.
Yeah, so I use aspirin as well for 4 weeks. And the dosage we could talk about, there's 300 milligrams, there's 100, there's 75. But I think any dose inhibits platelets, but the high doses give you an analgesic benefit as well in the perioperative period. So I use a slightly higher dose in hospital and then a lower dose when they leave. And I use it for 4 weeks. What about the role of compression stockings? Do you all use it? Have you ever had a patient dislocate their hip trying to take their stockings off or on?
Somebody else has to make them wear it.
Okay. All right, we'll move on.
We have a lot of help available in India, so anybody can just help them take off.
So what about this? This is a sort of a funny X-ray, the rotation, but would anybody use a cemented hip in this case, or cementless? This hip was cemented. I mean, there's some data to show that in the older patients, cemented hips have lower risk of early postoperative fracture than the non-collared cementless stems. So is there a role for cemented hips in your practices? Yes?
We do cemented in about 20% cases.
Yeah.
80% become non-cemented, and that decision is done on table sometimes, because when we broach, we find that we don't get a very good hold, then we switch to cemented.
Yeah. I used to cement, and now I have gone to collars, so I've stopped cementing. Is it age or is it bone quality? Tell me about the SING index in both of these x-rays. The one on the left's a younger patient, the one on the right is older. Who was using the SING index? How would you rate those? Yeah?
Well, you see the trabecular pattern in the proximal femur. And those are the tensile trabeculae, and if you see that those are prominently marked,
Yeah.
I think they were divided into 6 groups.
Okay.
Yeah.
So I just use the cortical thickness index at the bottom of the radiograph, 10 centimetres below. The one on the right, you can see about 2/3 of that diameter is made up of bone. And the one on the left, less than half the diameter is made up with bone. That's the cortical thickness index described 20 years ago. That's what I use.
So in a diseased hip, there is also always diffuse osteoporosis.
Yes.
So you cannot
because of
read
the
the
arthritis.
SINGS index in that. So
Yeah.
cortical index is a better one.
So the problem with the SINGS index is it's so much dependent on positioning of the limb. So the
Yeah.
reliability is very poor actually.
Yeah, that's right. Rotation of the limb. So if you look at a CT scan, if you rotate it, you change the cortical thickness index. If it's externally rotated or internally rotated. So I think if you externally rotate it, it looks thinner. If it's straight ahead, it looks thicker. That's true. You can see it on CT scan. Though I might skip forward, and because you want me to finish up, I'm assuming, because we're out of time. Collared stems. So there's who's using collared stems for their cementless hips? No? So what's the benefits of collared stems?
So the lower risk of fracture, but I personally believe that collared stem is really the legacy of direct anterior approach, because people were either undersizing these stems because they were so scared of fracturing in the direct anterior approach. So it has seen resurgence only after direct anterior approach. So if you are a little one size down, it will not subside and rotate and cause fractures. So I think there's enough evidence there's reduced risk of fracture with the collared stems.
Okay.
For a DORS type C type of canal in elderly osteoporotic patient,
Yeah.
I think it's more useful.
So is there a downside to using a collar?
Yeah,
Yeah.
may I?
Yeah.
What I feel is the downside is that collar gives you the pseudo security. The best way is to, in my practice, you feel the sound of the bone when you are broaching.
Okay.
And the moment the sound of the bone is confirming you that this is the right fit, with a collar probably you will put an undersized stem, hoping that the collar will support.
Okay. So
And all collared stems are not the same. Some of them have a uniform collar, so some of them have a graduated increase in thickness of the collar. So iliopsoas impingement is an issue.
iliopsoas impingement can be an issue.
Subsidence with undersizing is an issue. So
If you don't have collar when you are using a non-cemented stem, the surgeon tend to have a little better, in inverted commas, fixation, and may end up trying to use the largest possible broach he can use, and in that bargain he may slightly oversize it.
Okay.
But if you don't have, if you have a collar, you don't have to go for the largest one. Once you get a reasonably good fit, they will accept it.
It's reasonably
that
good.
may be the reason there is less risk of fracture when you use the collar.
Sure. Does it matter if there's a gap under the collar? No, it doesn't
Well,
matter.
it doesn't matter
Then
because
you have an
it's
uncollared
non-functional then.
If you've got a gap under the collar, you have an uncollared stem.
Okay, finally, can resurfacing make a comeback? You know, there's been some papers showing patients under 50 at 95% survival at 20 years. Great results in the Birmingham at 20 years on the Australian registry. You know, resurfacing overall compared to conventional has a slightly higher revision rate, but if you look at the ADEPT and the new ceramic on ceramic resurfacing, it's very low. And, you know, in male patients with the metal on metal resurfacing, it's low. With the ceramic on ceramic resurfacing, we're not seeing any difference between males and females. So, and there's also a polyethylene, thin polyethylene resurfacing that might become available. So I know David doesn't think that there's ever going to be a comeback for resurfacing, but maybe.
So first of all, I think you're the world expert on this, so we should listen to your opinion on this. My concern is just that it's no question, it's a harder operation
It
to
is
do
a harder
well.
operation, yeah.
And any of these operations, if we do poorly, are going to have a higher complication rate.
Yeah, good
So
point.
we've got such a good operation with cross-link polyethylene and ceramic heads
Mm-hmm.
with primary total hip. Maybe it'll be a comeback, but it should really be done in expert hands.
Okay.
I wish that it comes back because especially the BHR was an excellent implant.
Yeah.
The fixation was excellent, and the next thing closer to the BHR has been the delta motion, the
Yeah, depth.
ceramic on ceramic
Yeah.
anatomical head.
Like-
Probably that still I believe is the best fixation for the cup size.
Mm-hmm.
Unfortunately, from India it has been withdrawn. I think 2 years back.
Yeah, the delta motion.
Like
was-
we mentioned yesterday, I asked the question yesterday, I think a marriage of a resurfacing with a robotic technology might
Yeah.
be the future, depending on, I think Stryker has acquired Serve, so there is a chance.
And in India, where most of the patients are very young,
Yes.
we don't have primary osteoarthritis. So whether it's resurfacing or Birmingham mid-hip resection or a Meta or anything to have
Preserve
a second
bone.
bite at the cherry.
Yeah. Okay. But if it's avascular necrosis, that might be a contraindication for resurfacing. But what is the commonest indication for hip replacement in India?
It is the AVN.
It's
AVN.
AVN
So if the
and
femoral,
post-traumatic.
yeah, so if the femoral head is compromised with blood supply, then it may not be a good idea to preserve the femoral head. You may want to cut it out and get rid of it. Okay, we're out of time, I think, but thanks all for your expert opinions. Let's give the panel a round of applause.